Hello and greetings to all who have taken time to watch this presentation. My name is Thiruselvi Subramaniam and my co-presenter is Associate Professor Dr. Yannick Eller. We are both from across the world from each other, but we came together to work on this presentation as part of the initiative to work towards better patient safety and outcomes. I am an associate professor in IMU University, Malaysia. I'm an anesthesiologist by profession with a postgraduate certificate in medical education, and I'm also a certified healthcare simulation educator. I teach undergraduate medical students, and I'm involved in simulation activities for the healthcare professionals as well. As you by now know, we have prepared short webinars for the Patient Safety Week, intending to highlight some areas in patient safety management, or rather patient management, that can bring about improvement in patient outcomes. I use simulation in my teaching delivery, and debriefing is one of my areas of interest. I've picked an area of debriefing today that tends to get ignored because everyone pays a lot of attention to participants who are getting debriefed after an event, and assume that the person who's debriefing this group of people is doing, or rather are doing, what they should do correctly. The topic for today is thus debriefing the debriefer, strengthening patient safety through reflective practice. Debriefing is a vast topic that needs a lot more than 1 hour session, so I'll try to address some important aspects in this talk. As we go along, you may even realize that some of you have been actually doing something that is fairly well related to the debriefing itself. And I hope that this presentation adds some insight to the process of debriefing. We have no conflict of interest, and any videos shown today were recorded with consent from all concerned. By the end of this presentation, we hope that participants will be able to understand the relationship between debriefing quality and patient safety outcomes, recognize the value of debriefing the debriefer as a strategy to enhance debriefing skills, develop skills to provide a constructive debriefing practice using structured tools, for example, the PEARLs, which is what we will be sharing with you today. PEARL stands for Promoting Excellence in Reflective Learning and Simulation. It is an integrated conceptual framework for a blended approach to debriefing, and it was proposed by Drs. Walter Appick and Adam Cheng in 2015. I have added the reference to this paper by them in this slide. So what's the plan today? Well, I'm going to kickstart the session by giving a short introduction about debriefing, the debriefer, the benefits of debriefing, and the tools out there that can guide us to a structured debriefing that will help us achieve training outcomes and learning outcomes. Now that'll be followed by Dr. Yannick's presentation, where he will use one of the tools. As I mentioned earlier, he'll be using PEARLs as an example and take you through the steps in a interactive manner using some examples. Finally, we have prepared a very short video that you could watch and critique at the end of the session using the same tool to debrief a healthcare team who had just completed resuscitation of a patient who collapsed in the ward. There are positives and negative actions in this video, and we are looking forward to your take on the debriefer, who, by the way, happens to be me. How do we define or describe debriefing? First of all, we need to understand that debriefing is a process, one which many believe is where the learning occurs, and there is evidence to support this as well. Harvard Center for Medical Simulation describe debriefing as a conversation among two or more people to review a simulated event or an activity in which participants analyze and explore, synthesize their actions and thought processes and other information to improve performance in real situations later. Debriefing is a guided reflection guided by a debriefer who will guide the participants and help them reflect on their actions after the experience. Now, it could be after a simulation session experience or a real experience. It is an active, engaging session that is very much learner-centered, where unlearning and relearning happens. There are some definitions provided in the simulation dictionary to describe and understand debriefing. I've included the link to the SSH website here for you to download a free copy. Now, looking at the definitions in the dictionary, Lederman in 1992 called it a process in which people who have had an experience are led through a purposive discussion of that experience. A conversation between instructors and trainees that follows a simulation was the definition by another team. Fanning and Garber called it a facilitated or guided reflection in the cycle of experiential learning. One might ask, how is debriefing different from feedback? Well, there are differences, though both are essential for improving competency and fostering a culture of continuous learning in medical education and healthcare training. Here, I have listed a few obvious differences between the two. Debriefing is a reflective discussion that allows learners to analyze their actions, decisions, and emotions to gain deeper insights. It is supported by the framework of social, cognitive, and constructive learning theory. As for feedback, it's a process of providing information to learners about their performance to help them improve. Debriefing is very much learner-centered, while feedback is teacher-centered or facilitator-centered. Debriefing is a reflective process, but feedback is a focused response to a learner's performance or a skill, or it could be a skill or a clinical examination, and a direct feedback is given. So it's more one way when you talk about feedback. But debriefing is a two-way, interactive, and engaging action. So that is the difference between debriefing and feedback. Why should we debrief? What are the advantages? Well, debriefing allows self-reflection and identification of gaps in knowledge and skills among participants, helps to improve poor performance and reinforce good performance at the same time. It builds confidence, especially when it's conducted in a psychologically safe environment where the participants are able to voice their opinions and even acknowledge their mistakes, knowing that they are not going to be judged. Debriefing also helps to determine if learning outcomes are met after a teaching session or training session. And finally, debriefing could be a therapeutic tool after a traumatic event, where participants are able to vent and discuss with the debriefer and be able to accept some of the events that occurred, especially when it is something where the end up blaming themselves for the loss of a patient, for instance. So it is good to have the debriefing soon after the event. Where does debriefing fit into this process? Whether it's simulation experience or actual experience, it is conducted after the experience. For actual experience, it is conducted by the clinician who led the management of the patient. And if it is in a simulated environment and it's a simulated experience, it will be by a faculty in charge of the trainees or a simulation educator. How well is the debriefing being conducted? Has the debriefer created a psychologically safe environment for the participants to engage in active conversations and so on? Are the things that a debriefer, number 2, would be observing. So to identify the effectiveness of the debriefing process is why there is a need for this debriefer, number 2, who will observe and later on have a one-to-one debriefing session with the novice debriefer perhaps and give them some feedback. Now, debriefer 2, when they do the debriefing, they have to do the same structured debriefing after creating a safe psychological environment for debriefer number 1. When do we do debriefing? As mentioned earlier, right after the event. This is the ideal time to capture immediate reactions and observations. Hot debrief, or as we call panas, is done immediately, but a formal one follows within 24 hours. The more the delay, the less effective it gets, as memory and retention can be quite fickle, and we have a tendency to forget details. So it should be done in a timely manner. Pause and debrief, rapid cycle, deliberate practice debriefing are done in simulation experience, and they are done by stopping the simulation experience, giving the debriefing, and then continuing with the experience again. So they are a little different from what happens in the actual environment. How long should a debriefing last? Now, if it was after an event, it could take between 10 to 15 minutes. This is what we call as hot debriefs. Or it could be, the standard is about 20 to 30 minutes. 30 to 45 minutes would be if it involved more people and more disciplines or more departments in the management of a patient. So it can get more complicated, especially if it is a complicated case. But if it's a simulation session, it is said that the duration of debriefing should be at least 2 to 3 times the length of simulation. And simulation is usually not very long. It is only about 10 to 15 minutes max. So the debriefing would be 2 to 3 times that, or on an average about 10 to 20 minutes. Where we conduct the debriefing is also very important. The location of the debriefing after a patient safety event should support psychological safety, open discussions, and confidentiality. The optimal setting will depend on the urgency, team size, and event complexity. Generally, it should be a quiet and private room near the event location, but away from the patient areas if it occurred in the hospital setting. But if it occurred in the debriefing room, or rather in the simulation lab, then the discussion should be in the debriefing room. Virtual or hybrid setting is not really encouraged, but only if in-person is not feasible do we consider the virtual or hybrid setting. I have mentioned who generally does debriefing. It could be a senior physician or clinician if it is an actual environment. If it is a simulation session, then it could be a faculty or a trained simulation educator. Generally, the debriefing is conducted by someone with experience in debriefing and the content of discussion. So there must be some knowledge about what is the content of the discussion. The debriefer's role, whether debriefing team members after an experience managing a crisis or post-simulation, is the same. As long as one is debriefing participants or a novice debriefer, they are playing the role of a facilitator, a feedback provider, a guide for learning and improvement, creating a psychologically safe environment. And a debriefer should also be a neutral observer, as well as a time manager, because if you don't control time, the debriefing will go on and on and on. So once our learning objectives have been achieved, the session should stop, ideally. And they are also the ones to consolidate, reinforce key takeaways at the end of the whole debriefing session. What are the characteristics of a debriefer? They should be astute. Debriefing can lead to negative consequences like loss of confidence, demotivation, fear of making mistakes and getting scolded. So one gets afraid to even speak up when an error is noted, for instance. This occurs if the debriefing is not conducted in a correct or in a structured manner, creating a psychologically safe environment. That is one of the most important things in debriefing, the psychological safety, where participants feel that they are supported, that they can make mistakes, because it will help them get better in the future. So that is the challenge for the debriefer, creating this environment. If not done well, it can also be a form of trauma for the participants. Listening to this presentation about debriefing, I hope the audience has been able to connect the dots and visualize the benefits related to patient safety when debriefing after a critical event is conducted properly. Debriefing directly supports patient safety by fostering a culture of continuous improvement, psychological safety, and team communication. To sum up, there are a lot of advantages to debriefing the debriefer, because debriefing the debriefer improves debriefing quality and effectiveness. It enhances psychological safety, promotes self-reflection and lifelong learning, facilitates constructive feedback culture, identifies latent threats in simulation and practice, as well as strengthens team resilience, which is very, very important in terms of building a strong team during management of patients. I have included references that discuss and support these benefits. How do we conduct a structured debriefing? There are many tools out there available, and I have listed some here. They can guide debriefing of participants after an event or the debriefer after a debriefing session. When you go through all these tools, you find that they all have a lot in common. I'd say go with the one you're most comfortable with given your situation. We are using Pearls as an example. I quite like it because it is blended and it has elements of plus delta as well as advocacy inquiry in it that gives me the freedom to decide how I want to do the debriefing. Have you watched Monster Inc., the movie? There is an interesting and funny clip in it that demonstrates a classical example of debriefing. Well, you decide how well it is conducted and how you would want to debrief the debriefer. I'd like to now stop and allow Dr. Yannick to take over and walk you through how debriefing is conducted using the Pearls healthcare debriefing tool. Thank you.
Thank you very much for handing over to me, Thiru. Good morning, afternoon, and evening to everybody who's listening from my side as well. So my name is Yannick. I'm an assistant professor in the international setting. I specialize in simulation-based education, assessment, and faculty development. And I would like to give you some practical input, including snippets as of video files, which are from a course I designed, including a simulation in a simulation, which is because it happened during the COVID pandemic, so we couldn't simulate in person. That's why we simulated the simulation online, as well as snippets from the paper itself. You're going to find the text snippets in my slides I'm going to show you, as well as possibly audio snippets from here, which are unintended because we became parents 13 weeks ago, and my son, sometimes it's very loud and I can't avoid that. Sorry about that. Today, I will walk you through how the PERS framework can help us structure debriefing in a way that is practical and effective for simulation-based education. I will introduce key concepts and guide you through structured steps to ensure debriefing leads to meaningful learning experiences. To get started, I would like to make mention that I published an online article in the European Sting, which is a medical student magazine, because my medical students asked me to provide some more theoretical background on simulation-based education. I bridged the gap with a colleague to telemedicine, so that's maybe worthwhile to read as well, because it's on the course we're going to look at after, as well as that Michael Wagoner, who is going to be the student who's going to talk most during the video snippets, used to be my master thesis equivalent student, but that's finished right now, so I don't have any leverage on him. He gave me permission to use these video snippets, same as the other students during the course. Well, I additionally serve as the current Secretary General of the Special Interest Group on Patient Safety and Quality Improvement of AMEE, so I know that debriefing is central to experiential learning, also to patient safety in that case, particularly in healthcare simulation. Without structured debriefing, the effectiveness of simulation training is substantially reduced. Structured reflection and discussion allow learners to internalize lessons more effectively, making debriefing an essential component of skill acquisition and professional development. There's also several forms of debriefing techniques. So, for instance, the plus delta and the advocacy inquiry we also used during the course I mentioned. A crucial concept in debriefing is the identification of performance gaps. A performance gap is the difference between the desired performance and the actual observed performance. Understanding these gaps allows us to structure our debriefing questions more effectively. However, it is important to note that debriefing is not just about identifying weaknesses. We also need to highlight exceptional performances, as valuable lessons can be drawn from both successes and areas that need improvement. In the following practical example I mentioned before, so the course, please consider how identifying performance gaps can shape the discussion. And please also make no mistake that psychological safety is also very important. I can only recommend to read the paper of Jenny Rudolph on the safety container, which is under, if you look through the paper of Epic and Cheng, reference 73. I can only recommend to read that. To conduct an effective debriefing, we need to include 4 essential elements. First, active participation. This means more than just passively receiving feedback. Learners should engage in discussion and reflection. Second, developmental intent. Our goal is to foster learning and improvement, not just review performance. Third, discussion of specific events. We should focus on actual occurrences during the simulation, making the conversation meaningful and relevant. Fourth, input from multiple sources, as to say who's witnessing. Different perspectives help enrich the discussion and ensure a well-rounded learning experience. These elements help create a structured conversation between participants and educators, making debriefing more than just feedback delivery. Many novice educators face challenges when leading debriefings, which is not confined to novice educators. That can happen to each and every one of us no matter how experienced. They struggle to observe and structure the discussion effectively. They may find it difficult to keep the conversation engaging and meaningful. They often hesitate to provide open and honest feedback. Again, there's a recommendation to read the feedback with good judgment, also from Jenny Rudolph. One of the most common struggles is thinking of the next question to ask, of course, because of the cognitive load. This can interrupt the flow of the discussion and make active listening more difficult. A structured script, like Pearls, helps reduce cognitive load and supports educators in guiding a productive debriefing session. So much for basics of debriefing. So in the spirit of hearing more voices during a talk to improve knowledge retention, let's hear how Michael introduced himself back in the day.
Okay, hello. My name is Michael Wagner. I'm a student on the University Karl von Ossietzky University of Oldenburg, and I will be presenting the clinical trial for you momentarily.
Maybe a few more details you need to know about the course you're going to listen into. The course was called How to Medical Journal Club, and it was for sophomores. So the three second-year students you're about to hear, they had their first regular exposition to science, actually, because medical school doesn't include a scientific education, a regular one. This is the so-called small longitudinal research curriculum. The large one, the large LSC longitudinal research curriculum is used to be the master equivalent I mentioned before, and that's all during the modernized curriculum at the University of Oldenburg in Germany.
The topic is going to be about the safety and the efficacy of the BNT162b2 vaccine. I have one conflict of interest to declare, which is that I personally have received 2 doses of the vaccine. However, not in affiliation with the trial or anything, just, private, I guess.
So you just listened to the start of the immersion part of the simulation session. All the sessions were structured within 90 minutes. The second 45 minutes were reserved for debriefing. The first 15 were pre-briefing, so to reiterate housekeeping rules, the buy-in, the fictional contract, the netiquette to respectfully treat each other, and also to address each other as doctors. So the sophomores tried to role-play actual physicians, and that was one of the challenges within the hidden curriculum, so to say. But no more detail here. Dr. Wagner, any last things you would like to say?
I can't think of anything that I would want to say that hasn't been talked about already.
So thank you very much. Actually, the end of the immersion. What you also need to know is English is a second language to all of the students there. And the whole course was supposed to be a first step into the scientific realm, also using English as the language of science, because they need to be able to interpret the results on their own medical practice afterwards, instead of doing actual science. So that's why I mentioned in Germany, there's no regular scientific education within medical school. So coming back to Pearls, there's several stages which the Pearls is divided into. The reactions, description, analysis, and the summary part. Also some optional elements in between, like asking for the feelings, which I myself think it's very important because you need to be aware of what hurdles to overcome before actual learning. Also, we have to be aware of this multi-stage approach because this is a student course we're looking at as an exemplar, but I think this can easily be transferred to faculty development efforts, and that's why also I think it's important to practically look at video sequences. What's also, as you can see, recommended in the paper. So how can Pearls help structure debriefing? PEARLS stands for Promoting Excellence and Reflective Learning and Simulation. It is a structured framework designed to help simulation educators conduct effective debriefings. A good debriefing session is not just about discussing what happened, but about facilitating learning through reflection, analysis, and guided discussion. PEARLS provides educators with a structured yet flexible approach, allowing them to adapt their debriefing style to fit the situation and the learner's needs. Educators who have used the PEARLS framework report several benefits. The debriefing script is easy to follow, but requires some initial training to use effectively. So that's why it's also important to make the pre-brief with the learners themselves, in addition to what you prepare yourself for. Understanding the rationale behind the script improves its implementation. It helps novice facilitators by providing structured phrasing, making it easier to lead discussions. Even experienced facilitators benefit from using PEARLS as a guide. I mentioned this before. And using this framework accelerates the learning curve for new simulation educators. The PEARLS debriefing script is designed to support educators in three main areas. First, setting the stage, establishing an open, psychologically safe environment for discussion. Second, organizing the debriefing, so structuring the discussion with participant reactions, a review of key case elements, and a deeper analysis of performance. Third, formulating effective questions, helping educators guide discussions clearly and constructively. So this structured approach ensures that learners can reflect on their experiences in a meaningful way, ultimately leading to better knowledge retention and skill development. So in the end, we're trying to produce competent medical doctors. And in order to make debriefing effective, PEARLS suggests using a blended approach that includes three main strategies. Learner self-assessment, allowing learners to reflect on their performance and identify areas for improvement themselves. Focused facilitation, guiding learners to critically analyze events, leading to deeper understanding and reflection. And directive performance feedback and teaching, providing clear explanations and targeted teaching when needed. Each of these strategies has its advantages, and choosing the right one depends on the specific scenario and learners involved. So then, to decide the best strategy for analyzing a performance gap, educators can ask themselves three key questions. One, is the rationale for the performance gap clear? For example, did the participant lack knowledge, or was the issue more related to decision-making? Two, how much time is available? A structured discussion must fit within the allocated time frame, of course, while ensuring key learning points are covered. Three, does the performance gap relate to cognitive, technical, or behavioral skills? Different types of gaps require different approaches to coaching and feedback, certainly. Keeping these questions in mind helps structure the debriefing in a way that maximizes learning. So before we move on, showing the application. To summarize what we've covered, PEARLS provides a structured yet adaptable approach to debriefing. It helps educators guide discussions effectively and address performance gaps. It benefits both novice and experienced facilitators by enhancing the quality of debriefing sessions. By integrating PEARLS into our debriefing practices, we can improve learning outcomes and ultimately enhance patient care. Let's move on to the application exemplar and listen to our soon-to-be physician colleagues. And what you're about to hear is reactions.
Proceed after script. How are you feeling, Michael?
I'm feeling good. I think normally I have a kind of a problem with public speaking, even if it's just for a small group like this. I don't know why. But somehow this, I think, went over better than my usual presentations go. I don't know if it's because it was in English or... But yeah, what you said about that trial is a lot to unpack. I also thought that, and I didn't include a lot of things where I thought that maybe I should, but it was just so many factors.
Next will be a short summary done by Katharina and a bit of directive feedback by my former self.
Description. Can somebody of you, except Mike, can summarize this presentation from a medical point of view, that we're all on the same page, maybe?
I can give it a short try, I think. So I think it was a placebo-controlled and observer-blinded study, and they have a control group and the vaccinated group with the 1-to-1 ratio, and they want to see the efficacy and the safety of this new vaccination, and also made some subgroups to see how this is specified in these groups, but we already talked about that these groups weren't that well chosen.
And how did they assess the safety and efficacy? That's maybe some point to mention as well. Via electronic diaries. Yeah.
Here we go for the analysis part. Next, you're going to learn a self-assessment. And also what my former self and Michael will be mentioning, as well as the slides, is some tools I provided to the participants before. The 5 rules of thumb, just some basic information about how to interpret science. As well as he's referring to a discussion we had during the immersion in our roles as physicians, all of us. So that's what he's going to mention.
Aspects of the case do you think you managed well, and why, Michael?
I hope that I managed to deliver kind of this whole hunk of information relatively compacted without leaving too much crucial information out. I hope I definitely did leave some information out. But I hope I managed to select the most important information to present.
So is there any challenging aspect you would like to have feedback on? Maybe like did the listing I provided in between of what phases of a clinical study mean, did that help anyhow, and help to draw the line in between why it's possible to make a difference in between the phases?
It definitely helped, first of all, because I wasn't aware like how much this exceeded the usual or what a usual phase 2 trial looks like. And I wasn't quite sure how to what to make of it, but I ended up going with that. I thought because of the situation, because of the urgency, that it was a positive point, but the discussion afterwards definitely showed that also there are some bad points about it, and definitely some ways to cover up and to make it look better than it actually is.
So we just referred to the list we used from Cancer Research UK during the immersion in our roles as physicians, discussing what phases there are for clinical trials. Next, you're going to witness focused facilitation, and I think Michael mentions some very central fears we're all going to remember during the COVID pandemic, and I think that's something to show how much they learned during that course, and stay professional.
Any other points which were very challenging, or would you'd like to have feedback on, Michael?
One thing maybe that kind of goes into what we just talked about is that, because it's such an emotional topic, and what I've kind of felt is that, when I go on to critique something like the BioNTech trial, and, it might be perceived as me critiquing the vaccine itself and like coming over as like an anti-vaxxer or something, which of course is something that I wish to prevent. But of course, I knew that this was not going to be received as such in this group.
Absolutely.
So the final closing bit, I think I can let you watch on your own and leave the closing to my former self. I would hereby like to thank you for watching my talk, and I very much hope this is going to help, including the pearls yourself. And I would like to give back to Thiru after my former self closes the session. Thank you. Bye-bye.
We've reached the last part. So any outstanding issues before we start to close? No? Okay. So maybe for summary, we will do this learner guided. So I'd like to close the debriefing by having each of you state one or two takeaways that will help you in the future.
So what I really learned from this is that, especially when looking at clinical trials where, corporate money is behind the trial, you really need to watch out for them, like kind of trying to persuade you into believing that it's better than it is, just to profit, basically.
Absolutely,
I think that's the main takeaway for me, at least.
Reading papers and working within a journal club or discussing in a journal club is just like a muscle. So you can train it, but it's not like riding a bike. You can also unlearn it. That's the problem, because science goes forward all the time. There's a progress, of course, and they also develop in how they sell their product, of course, especially if it's pharma people. Yeah. Okay, great. Other take-home messages.
The one you mentioned was that reading such studies is the muscle to train. And that whether in the future I will be joining a journal club or not, to read the whole study from time to time regularly is a good point to take home.
Well, thank you very much for that. I think you're sensibilized for that now, and we don't have to further elaborate on that. Thank you very much for today's appointment. I think that's been great. And I think I can stop the recording now.
Dr. M, why did you give ephedrine to the patient? I told you to give epinephrine every 3 to 5 minutes, isn't it? It's a good thing. Stephanus Vicky saw the ephedrine ampule and, noted to us. So we were able to change it and give epinephrine from then on and managed to get the patient back after the next round of CPR.
I'm so sorry, doctor. The ward was so noisy, the monitors were bleeping, and all I heard was ephedrine.
Okay, let's move on. Can one of you summarize what are the issues that we had to deal with today? Anyone?
Okay. We had a 65-year-old gentleman. It's a known case of diabetes and hypertension, and he presented with chest pain, and we diagnosed him with an acute myocardial infarction. Before we could start treatment, he collapsed, and then we commenced CPR, but there were issues, and that led to a delay in the return of spontaneous circulation.
Okay, let's analyze the case that we did today. Looking at the case, what do you think went well? What you did well, you think? And what you would want to do differently in the future if something else like this happens to you?
Okay, doctor. Because earlier I thought I heard epinephrine, Okay.
But I was participated in resuscitation only once. Therefore, I do not have a voice there, as I thought Dr. M would know everything.
Okay.
So I think I will change that in future, Doctor.
Okay. What about you?
I thought everyone worked well and everyone knew their roles.
Yes, I agree. We work well together. But for my part, I think I should have gotten my colleague to call on the doctor instead of us doing the same task together.
Okay.
So that would save time in the future.
Okay.
So guys, I hope you learned some new things today, and because patient safety is very important, and use whatever you learned in your future practice. Okay.